Hi there, I am Lissa Fansler. I currently am a licensed veterinary technician in the state of Texas at an emergency hospital called Animal Emergency Hospital of North Texas. I started my uh, professional career out as a military. I ended up being medically retired. Then I went back to school in North Carolina. I went to vet tech program where I became an RVT. When I came to Texas, I then was grandfathered in as an LVT. My entire veterinary time has been in emergency medicine, except within the last few years, I actually started teaching college veterinary assisting classes. I would like to thank Dr. Libby Ramirez and Elizabeth Lowry for reviewing this presentation and giving me feedback that assisted me to better make this presentation. So let's get started. So today I'm going to be talking about capnography. Now, to me, capnography is the ultimate monitor. It tells you so much information about your patient, how your patient is doing, whether it is under sedation, or if it is even just a simple anesthetic procedure, or even a more advanced anesthetic procedure. Overall, though, capnography is going to help you throughout the entire thing. So let's get started. I'm going to be touching on quite a few topics today. We're going to talk about some basic terminology that will be utilized and help you understand the various things that we're going to talk about in capnography. We'll talk about background and physiology, different types of monitors, examples of them, how to set some of them up, as well as even some tips on if you're having some difficulty. The majority of this presentation will be at the end, the analysis portion. This is where we will actually look at some capnography waveforms, and we will determine normal from abnormal and what makes them abnormal and what does that tell us. So here are a variety of terminology pieces that we're going to be learning. And we're going to just start at number one and work our way through. So on number one, when you see this, this is a measurement of alveolar dead space. Now, an increase in this suggests that there's an increase in dead space ventilation. Hence, this is actually an indirect estimate of VQ mismatching of the lung. And we'll talk more about VQ at the end, but this has a pretty important aspect whenever we're talking about capnography. Just briefly to tell you, VQ is dealing with V for ventilation and Q for perfusion. So when you see VQ, whether it has a dash or slash in between or not, VQ is talking about the air that's inhaled as well as the blood flow. Now that second topic, that is our talking about the alpha angle. Now, if you look in this image here, you'll see that first angle, that is our alpha angle. The alpha angle is an angle that's between phase 2 and phase 3 of our capnograph. The alpha angle is used to evaluate the VQ ratio. So when VQ mismatches are present, then we'll have an alpha angle that's actually greater than 90 degrees. And so we remember VQ is dealing with ventilation and perfusion. Number 3, we're talking about that beta angle, as you can see in this image here. This angle is between phase 3 and the descending limb of the inspiratory segment. Now, normally this angle is going to be as close to 90 degrees as possible. This angle is going to be used to evaluate rebreathing. If we are seeing rebreathing, if that is actually happening, then we're going to see that this angle is going to get greater than that 90 degrees. Next is capnogram. This is the name we're going to use for the CO2 digital waveform. So like this picture, if this was just a constant running image on our monitoring machine, this would be a capnogram. Now there are two main types. One is timed or time capnography, and the other is exhaled volume or volume capnography. Now volume capnography does not have what's called the inspiratory segment. Timed capnography is pretty simple, and for the most part, it's adequate for clinical use. So more than likely, this is what you're going to see used in practice. Now, capnography, this term is the graphic display of an instantaneous CO2 concentration versus either time or expired volume during a single respiratory cycle. Captometry, this is the measurement and visual display of CO2 on a digital or analog monitor system. The maximum inspiratory and expiratory CO2 concentrations during a breath-to-breath cycle, this is what's going to actually be displayed. CO2, this is the abbreviation for carbon dioxide, which is a colorless, odorless waste gas that's produced by respiration. The next one, number 8, this stands for end tidal CO2. This is the expired gases from the alveoli. This is the level of carbon dioxide that is actually released at the end of an exhaled breath. Now, this term is pretty interchangeable with the term or abbreviation PET CO2, which is number 16 on this slide. The expiratory segment represents the exhaled carbon dioxide concentration from a single breath. Now, it will be divided into 3 phases. With certain circumstances, we can potentially even see a 4th phase. So if you're looking here at this image, you'll see the green is our expiration. This is going to be our expiratory segment. So our flat line or 0 is going to be phase 1, then it goes up phase 2 to the alpha angle, across phase 3 to the beta angle, and then that is when the inspiratory segment begins. Number 10, this is FCO2 or fractional CO2 concentration. This is the measurement of carbon dioxide within arterial or venous blood. In CO2, so IN CO2, this is the inspiratory CO2. This is an indication of faculty equipment that is not working properly, unsuitable fresh gas flow rates, so maybe it's too low or too high, or the big one is exhausted soda lime absorber. Next one, PaCO2. Now, there's 2 different ones, as you can see. There's one that has a capital A and one that has a lowercase a. They are different. The one that has capital A, so PaCO2, all capital letters, this is the partial pressure of carbon dioxide in the alveoli. Whereas PaCO2 with a lowercase a, that's the partial pressure of carbon dioxide in the arterial blood. Now, if we don't have the A in there and it's just PCO2, this is strictly partial pressure of carbon dioxide. And this can be the measurement of carbon dioxide, whether it's arterial or even venous. PET CO2, this is partial pressure of CO2 at the end of expiration. It provides information about the adequacy of our VQ after resuscitation, as well as cardiac output when it's increased. A lot of times this is interchangeable with EtCO2. The only difference is PET CO2 is primarily going to be used when we're dealing with resuscitation and increasing of cardiac output. Phase 1, This is that respiratory baseline. So as you can see, we've got that flat line there at the bottom. That should be the line that's indicated by a 0. That's your baseline. Phase 2 is that expiratory upstroke. So we're going to be going almost all the way up to that alpha angle. Then we're going to plateau with phase 3 with our expiratory plateau. Now, this is where it can get a little tricky. Sometimes we can have a phase 4. It's not shown in this image, but we will talk about it later. And that's called the inspiratory downstroke. Next is our PvCO2. This is the partial pressure of carbon dioxide in mixed venous blood. Tidal volume. This is the amount of air moved in one breath. That means one inhalation and one exhalation. Then lastly, our VQ ratio. The V is what's going to be standing for ventilation, that air that we actually inhale. And then the Q is standing for perfusion, which is ultimately for blood flow. A VQ mismatch occurs when part of the lung receives oxygen without blood flow or blood flow without oxygen. Now, this happens if you have an obstructed airway for any reason, really. The VQ mismatch can then cause hypoxemia, which, as we should all know, can lead to a respiratory arrest. Now, in 1943, a man named Carl Left introduced the first infrared CO2 measuring and recording device. Now, ultimately, there are 5 physical methods of measuring entitled CO2, and even a chemical one. But the infrared method seems to be the least expensive and most compact. Now, the country of Holland, back in 1978, was the first country to adapt or adopt capnography as a standard of monitoring during anesthetic events. Now, capnography is ultimately an indirect monitoring measurement that allows assessment of the systemic metabolism, cardiac output, pulmonary perfusion, even adequacy of ventilation. It's going to help us diagnose hypoxia. That way we can then do corrective measures quicker. That way that hypoxia does not result in brain injury that's not reversible. It's going to provide information about CO2 production, pulmonary perfusion, alveolar ventilation, respiratory patterns, even how well is the body eliminating that CO2. Now, when CO2 is dissolved in plasma and measured by blood gases, it's known as the arterial partial pressure carbon dioxide, or PaCO2 with a lowercase a. Now, under normal circumstances, our entitled CO2, the PaCO2 with lowercase a, and then the alveolar CO2, or the PaCO2 with capital A. Under normal circumstances, these are all equal to one another, give or take a very small margin. This is because of the extreme proximity of gas exchange between the alveoli as well as the pulmonary capillaries. Now, with the use of capnography, monitoring staff can prevent more than 90% of avoidable anesthetic accidents. It has shown that it can facilitate better decision or better detection of potential life-threatening problems than just clinical judgment alone. Capnography is superior to pulse oximetry for the prompt identification of both apnea and airway mishaps. This is because SpO2 changes, well, they're delayed, whereas our entitled CO2 measurements are more instantaneous. even when we're using a side stream capnography unit, which we'll talk about later, even then, it's still significantly faster between that and the SpO2. We're going to see those changes much faster and detect them faster and be able to help eliminate the problem versus just monitoring our SpO2. Now, CO2 is measured between the patient and the anesthetic machine. There will be a device, the monitor sensor, that's placed between the endotracheal tube, patient end, and then the breathing circuit itself. This device is then connected through a sampling tube to the proper monitor that has been calibrated appropriately. When alveoli are not being properly perfused, CO2 is unable to diffuse out of the blood. So when the lungs get perfused, then that CO2 will be excreted. So that means that any abrupt decrease in CO2 or end-tidal CO2, ET CO2, this can actually be an early and very reliable indication of an impending cardiovascular collapse or even cardiac arrest. End-tidal CO2 can also be a very reliable resource to assess the effectiveness whenever we're performing CPCR. Now, under anesthesia, we can trace the flow of gases. Here we have a picture that shows how it flows through an active cycle. Now, yes, we have a human in this image. However, this falls for the same with our veterinary patients. The machine is going to push the gases out to the patient, whether that's through a ventilator or just through a normal breathing circuit. The gases are going to then pass through the breathing circuits down to the patient. The patient inspires the gases. The gas exchange occurs, which places O2 in the circulation and removes the CO2 from circulation. The CO2 then travels back through the airway. As the gases are exhaled, they're going to pass the capnometer. This is the device that is going to read and measure the end-tidal CO2. And those exhaled gases will also be eliminated by the scavenger system, or also some of them will go through the CO2 absorber. Now, there are three forms of CO2 that gets transported within the blood system. About 60 to 70% of CO2 is going to be actually attached to bicarbonate ions. Then we're going to have 20 to 30% that are attached to proteins within the blood. And lastly, we'll have that 5 to 10% that is attached to plasma. And this is actually what is being measured and monitored whenever we are watching end-tidal CO2. Now remember, the site of gas exchange, as we see here, is going to be the alveolar capillary beds that lie between the blood and the air within the lungs themselves. Now, normally, our end-tidal CO2 values need to be between 35 and 45 millimeters of mercury. Now, if we have values above 45, this means we're having inadequate ventilation. Well, that means ultimately we need to provide ventilation. This is when we would do partial pressure ventilation or giving them a breath with that rebreathing bag. Now, when we have increased periods of hypercapnia or increased levels of end-tidal CO2, this can lead to myocardial depression and respiratory acidosis. Now, the highest that end-tidal CO2 should ever get is roughly 60 millimeters of mercury. This high number can actually be used to help the body naturally turn on the respiratory centers of the body. That way the patient can start breathing on their own. This is especially important when we're using a ventilator or we're using a paralytic that caused the diaphragm and the other muscles to stop giving breaths. And we want them to start coming out of it, or we reversed it, or it's starting to wear off. Now, CO2 can be measured in three main ways: colorimetry, capnometry, and capnography. Colorimetry provides continuous, semi-quantitative, entitled CO2 monitoring. It has three color ranges: purple being less than 0.5%, tan 0.5 to 2%, and yellow greater than 2%. When using colorimetry, normal entitled CO2 readings are going to be greater than 4%. Limitations do apply to colorimetry though. Even though it's a useful device, it mostly is going to confirm endotracheal tube placement, but only in patients that are not in cardiac arrest. With patients in cardiac arrest, a value of less than 0.5%, this device is virtually going to be of no use, confirming that the endotracheal tube is in the right place or not. And that's because the tube could be in the esophagus, the circulation isn't bringing enough CO2 to the lungs. So ultimately, in non-arrest patients, this device is actually going to be 100% sensitive, while in about 69% of patients with cardiac arrest, it will be helpful. So ultimately, colorimetry is not commonly used. The membrane in a colorimetry device will turn yellow, which implies that we have greater than 2% entitled CO2. And this means that the device may be contaminated with acidic substances like gastric acid, lidocaine, epinephrine, things like that. The device is unable to give a reading when it becomes clogged. So if it's broken, if there are secretions within the device, then this device is useless. Now, the other two methods of measuring CO2 is going to be capnometry and capnography. Capnometry gives numeric values, whereas capnography gives a visual graphic representation. Now, both monitor entitled CO2 by evaluating samples of the exhaled gases from the anesthetic circuit through a very specialized sensor. And there are going to be two main types of adapters or sensors. First is mainstream, and the second is side stream, as you can see here in the two images. Mainstream, this is where the CO2 sensor is located between the endotracheal tube and the breathing circuit. Again, we have advantages and disadvantages for both of these. So the advantages of the mainstream sampling, there's no actual sampling tube. Well, that means we can't have any obstructions. It has no effect on it if we have pressure drop. If we have changes in water vapor pressure, there's no effect as well. We will see no pollution. We won't see any changes in the capnograms due to non-disbursement of gases. There's absolutely no delay in recording or readings, and they're pretty suitable for our neonates. However, mainstream does have some disadvantages. Now, the newer sensors are very lightweight, which minimizes traction on the endotracheal tube. However, The older versions are pretty heavy and sometimes can even cause the endotracheal tube to become dislodged. A lot of times, mainstream do have long electrical cords, but the unit itself is lightweight. Facial burns have been reported with the earlier versions, but with these newer sensors that we have out nowadays, those have been pretty much eliminated. The sensor windows may clog with secretions. However, they can be replaced easily as they are actually disposable. It's difficult to use in unusual patient positions, like if we have a patient in prone position, then we're going to probably have a little bit more difficulty using this. The newer versions use disposable sensor windows, which does mean that we are eliminating sterilization. This can be a positive or a negative depending on your school of thought. Now the side stream, this is a sensor that is in the main unit, and CO2 is aspirated through a sampling tube that's connected to a T-piece that's located at the endotracheal tube and breathing circuit. Again, we have advantages and disadvantages. Some advantages, well, honestly, it's pretty easy to connect. You don't have to worry about sterilization. It can even be used on awake patients, even if they're in abnormal positions like prone, and it can be used in collaboration with oxygen administration, like with nasal prong O2. Now, again, we do still have some disadvantages. There is a slight delay in the recording due to moving gases from the breathing circuit through the sampling tube to the actual monitoring unit. This also means that that sampling tube can become obstructed, and any changes in water pressure vapor or pressures, well, that can cause an effect on the CO2 concentrations. Now, deformity of capnographs, especially in our younger patients, can be seen with side stream, and this is due to dispersion of gases in the sampling tubes and dilution of the gases due to fresh gas flow. Now, here we have quite a few different types of CO2 monitors that you may or may not see. We have anything from our small one over here on the right-hand side. It's about the size of your palm of your hand, or you can have a full-size monitor like the one to the left, or even portable handheld units like the two on the left. So it just depends on which one your practice is actually keeping as to what kind you will have. But when it comes to the CO2 and how it reads, generally, if you've got a mainstream or a side stream, you're going to still be reading the same things. Now, when using a capnography monitoring system, the airway adapter should be placed between the breathing circuit and the endotracheal tube. This ensures that the gases that are being tested are directly from the patient and have limited dilution risk. Every capnography monitor does have to be calibrated when any component is changed. This should also always be done by the manufacturer's guidelines. Now, for the most accurate results, normally we're going to take and monitor, calibrate the monitor. We're going to make sure it's zeroed out to room air. And at the end, we will test it. So this is where we administer a gas with a known CO2 concentration to verify that it's reading the accurate amount. Now, one method that I have used in the past and have seen is you use your own breath which most of us are going to have a normal waveform and a value between 38 and 42 millimeters of mercury. So discipline is the key to success when we're dealing with capnography. You can receive maximum benefit from capnography if you follow some of these guidelines in your day-to-day anesthetic and even sedative practices. You want to make sure to maintain and calibrate your monitor as the manufacturer's guidelines stipulate. Again, for accurate measurements, we always want to make sure that we have calibrated and tested to ensure that our monitor is working properly. Now, before any interpretations are made of PET CO2 or entitled CO2 readings and waveforms, one should ascertain that it's functioning correctly, that we are not seeing any contamination, so secretions or mucus, because these are going to distort our waveform. Now, we sometimes can have a partial obstruction, maybe a droplet of water. Well, this can still alter our waveform. Even leaky sampling tubes can lower our PET CO2 measurements or entitled CO2 measurements. So again, always checking to make sure that monitor is functioning properly is going to be one of the key points when utilizing capnography. Now, low-level positioning of the monitor is going to facilitate condensed water and even secretions to move towards the analyzer, thereby results in blockages. So we always want to have the monitor above the level of the patient so we can prevent any of those obstructions from going up the sampling tubes. It's preferred that the capnograph is above the level of where the patient is at. This prevents it, especially those condensations that we see during respiration. We also want to make sure that if we are using a side stream with a sampling tube, that sampling tube needs to be vertical. This means that it's going from the patient upwards towards the monitor. We don't want it going hanging down and then looping back up. We always want to make sure that it is going vertically. This means that water droplets, secretions, any aerosols, it ultimately stays in the breathing hoses instead of contaminating the sampling tubes and altering our capnogram. The sampling tubes can become occluded pretty easily. Some units either increase the sampling flow or reverse the flow in order to purge when there's a drop in pressure. And sometimes we can have that can be sensed. So this will help clear those secretions from the tube. If it's not cleared, ultimately you just need to replace the sampling tube. It's that simple. We always want to make sure those liquids that enter the main unit of the analyzer are getting trapped in a specific trap unit. If they're not, they can actually cause corrosion and residue, which then can make the analyzer go bad. Now, in earlier capnography units, there were filters that were required in order to decrease the chance of moisture contaminating the device. Newer ones have moisture trapping mechanisms in order to do this. Just depends on what type of unit you're using, whether or not you have a filter or you have that trapping mechanism. So how are we going to analyze these waveforms? Well, ultimately, when we look at them, we have to evaluate several aspects in order to come to the conclusion of what it's trying to tell us. We're going to look at the frequency of each individual waveform, the rhythm, the height. Are they returning to baseline? and most of all, just the overall shape. All of these aspects are going to help us understand what we're seeing when we read a waveform. So now let's get started on some waveforms and go through what they should look like and how to tell what we're looking at. So here we have a normal adult capnography waveform. So you'll see if this was to continue outward, just keep going and going, it's going to occur with each breath at the beginning of exhalation. It's going to remain at a steady rhythm with the normal breathing rate. Phase 3 should go no higher than the normal entitled CO2 reading value. So if you are getting a 37, then the phase 3 plateau should go no further than that 37. Baseline. So at the end of that inspiratory segment, prior to the beginning of the next breath, the waveform should fully return to baseline or 0. The shape, remember, we want that alpha and beta angle to be nearly 90 degrees. Now, here are 3 different examples of instances where we have esophageal intubation. So frequency, well, they will not really be regular. Their rhythm's not going to be very regular. And generally, it's not going to go above baseline. And if it does, usually it's going to be very tiny, tiny oscillations that maybe go up to 1, kind of like the first and middle image. Generally, the reading will be completely at baseline and no real shape to it. Normally, you'll see the line follows baseline since there's not any carbon dioxide actually passing through the tube to be measured. But if, say, for instance, there's CO2 in the stomach, then you can see fluttering like waveforms, but nearly at baseline, similar to that bottom image. Also, when using mask ventilation, those alveolar gases can actually be forced down the esophagus into the stomach. Again, we are going to see those abnormal waveforms due to that improper ventilation. Next is our apnea. We all know apnea is where they are stop breathing on us. We're not going to see any frequency, no rhythm, no height. Ultimately, it is baseline. It's at 0, it stays at 0, there's no shape to it. Now, this can be due to other reasons than just apnea. It can be ventilator failure, maybe something got disconnected, maybe the patient even was accidentally extubated before you knew or before you wanted it to be extubated. Hyperventilation. Generally, our frequency is going to be pretty regular. Same with our rhythm. However, the height of the waveforms are going to reduce gradually. They will go back down to baseline and their baseline will stay at 0. Generally, the shape of them is going to be pretty close to normal. With hypoventilation, again, our frequency and rhythm are going to be regular, but instead of decreasing height, with hypoventilation, it's going to increase. Again, each waveform will come down to 0, and their shape is generally pretty normal to what our normal adult would be like. With hypothermia and even reduced metabolism, we'll see some changes as well. Our frequency is going to be pretty regular with pretty regular rhythm. The height will be decreased, and baseline, usually it's going to remain at 0. So sometimes you may have something that looks at something similar to something else. This is where critical thinking and troubleshooting comes into play. For instance, if you remember just earlier, we have decreased height in our hyperventilation, and now we're seeing decreased height in our hypothermia. They both go back to zero on waveforms and baselines, regular frequency and rhythm. So this is where you would have to evaluate your patient and critically think and look, is my patient breathing too much, or are they just getting too cold? Spontaneous ventilation. This is something we want to see when we're doing CPCR. The frequency is going to be steady with each breath. Same with the rhythm. Now the height, it's going to go from that shortened height that we see in image A, and that's where we are giving positive pressure ventilation. Well, once we get them where they're breathing on their own, then we're going to start seeing regular height, kind of like the image on the left, or the end of the image on the image B, where that red arrow is. Baseline still is zero, but the shape is going to be different. The alveolar plateau, or phase 3, this is actually going to be shortened. It's not really going to be flat. It's going to be kind of rounded. Now, when we have exhausted soda lime or our exhausted CO2 absorber, we're going to have some changes as well. Frequency and rhythm, they're pretty much going to be regular, but it's our height and baseline that's going to be adjusted. The height is going to gradually elevate. It's going to go from normal and then gradually go up. But in some cases, it can remain the same due to hyperventilation. Another way to tell that you're dealing with exhausted soda lime versus hyperventilation is look at where your baseline is. Where is phase 1? Is phase 1 touching zero, or is it elevated? If it's elevated, like in these 3 images, then you know you need to change your soda lime. Cardiac oscillations can also be picked up whenever we are monitoring our capnography. Now, ultimately, everything remains normal except the shape, and the shape starts at the end of phase 3. So you're going to see ripples seen down that alveolar plateau and the descending limb. And that's going to take and just be where the heart, its movement is causing those oscillations to occur. Now, in cardiac arrest, we can pretty much see variations everywhere. Our frequency may be normal, it may be varied. Our rhythm, same thing. And as you can see in this image, even our height can change. Now you can see here, baseline is always going to be zero, but even the shape can be changed. Generally, in cardiac arrest, our capnogram is going to be narrow. We still might be able to see that flattened phase 3 plateau, but it's so short. Now with asthma, COPD, like bronchospasms, airway obstructions, a lot of this we can see in our cats. We can have regular frequency, rhythm, and height, baseline at zero, but phase 2 and phase 3 are prolonged, which means we're not going to actually see a true alpha angle. We'll still see our beta angle, but we won't see that alpha angle. Now, when we go to give a treatment with a bronchodilator, as you can see here, we go from what we see with the bronchospasm or airway obstruction back. Once the dilator is given, we see back to normal. Now, this can go back to the abnormal, but it just depends on the severity and the current problem that we're monitoring. Now, if you remember back in the beginning, we talked about our phase 4. So frequency, we can see this regularly or irregularly, same with the rhythm. But ultimately what this phase 4 is it's a little bit of a bump at the end of phase 3 as we go into our inspiratory segment. Now, baseline is still going to be set at 0. Everything will go back down. But it's just ultimately a terminal upswing at the end of that phase 3. Now, a curate cleft, this can be regular or irregular, and it's going to be dependent on the actual situation. And same with rhythm. The cleft goes below phase 3, then back up to phase 3 before going into the true inspiratory segment. We will still see a baseline of 0, but ultimately it's just got that added dip and rise where that beta angle is located. A lot of times we'll see this when we have muscle relaxation that is starting to wear off, and even manipulation in the abdomen during a exploratory surgery. Now, sometimes our connectors may become disconnected, and we might see a partial disconnection change. Again, frequency and rhythm are going to be regular or irregular depending on the frequency and the severity of the disconnection. The cleft will go below phase 3, so it's an added dip, but it also has a little bit of an oscillation to it before that inspiratory segment actually begins. And this is just a slight disconnection of our mainstream sensor. Now, our sample tubes can have a variety of problems. We can have loose connections, cut tubing. Those are usually our more common ones. Loose connection will have generally a phase 4 that is flat. Cut sample tubes will have a sharp pointed phase 4. So as you see here, we've got on the top image, these are some leaks. So we're using a nasal cannula or maybe a face mask. The middle image, this is a break in the tubing or even a loose connection. We see that flattened phase 4. Whereas if we have a slit tube, we see that cattail up type of image. So that phase 4 is a sharp point and then comes down into that inspiratory segment. Then we have expiratory valve malfunctions. This is where we're going to have a prolonged phase 2, slanting of this descending limb of inspiration, as well as a baseline that's going to be elevated. Generally, the height is shorter due to the elevation of the baseline reading. The prolonged phase 2 and slanted descending limb of the inspiratory segment are those identifying factors of the shape. Inspiratory valve issues. Now, we generally have 2 types, a sticky valve or valve malfunction. Frequency and rhythm generally remain pretty normal or regular. Now, with a sticky valve, we can see a mini dip in the alveolar plateau or phase 3, and that'll be at the beginning of the inspiratory segment, as seen or noted in red in that top image. With a valve malfunction, the inspiratory segment is actually sloped or slanted. Baseline is usually elevated above zero, or no true baseline is actually noted between the inspiratory segment and the start of phase one. So as we can see in that bottom image where it's noted in red, this is generally seen in rebreathing instances. For contamination of our monitor, ultimately, we're just going to see a sudden rise in both baseline and the height of the waveform. Everything else is pretty much going to stay regular and normal, but that baseline value where it sets at and the height of the actual waveform. Now, in some instances, especially our smaller patients, we can potentially have dilution of endotracheal, the EtCO2, by our fresh gas flow. Now, generally speaking, we're not really going to see much difference, but except the shape. There's not going to be an obvious beta angle. Usually, the beta angle is actually going to be kind of wavy, as seen in this image here. Again, this is pretty common in the really tiny patients, the ones that the gases that they're exhaling are being diluted by the gases that they're receiving. With emphysema, we're going to see regular frequency and rhythm. The alpha angle will generally be higher than the beta angle. The baseline does stay at zero, but when it comes to that shape, the phase 3 slope is ultimately reversed, meaning it's going down from left to right. With malignant hyperpyrexia, the difference is baseline will be zero until the soda lime becomes exhausted. And the soda lime is going to become exhausted because the height of the waveform is going to keep increasing. So it's just going to keep going from normal up to an extreme high normal. And again, that's going to stay like that until the soda lime is exhausted, and then our baseline will also be increasing as well. Now, pregnant patients, we're going to see a regular frequency and rhythm. The height is going to increase that phase 3 slope. So it's going to be going upwards from left to right. Baseline still is going to be zero though. It's just that phase 3 slope is going to be going upwards from left to right. Now, with acute decreases in our cardiac output, we can regularly see changes in the height of our capnography or capnogram. As the liters, the heart is pumping out, decreases, so will our entitled CO2 and our phase 3 height. Baseline is still going to be zero. Shape will still be normal. Everything else will be normal except that shape is just going to keep decreasing down. Now, sometimes you may use a Bain system or a Mapleson D breathing circuit. Now, you'll note that that inspiratory wave is going to be smaller, and that's because of the rebreathing. This is pretty much a signature capnogram when dealing with a Bain system or Mapleson D circuit. It can be regular, irregular. Baseline can sometimes even be zero or elevated. But ultimately, the deciding factor is that inspiratory segment. it's smaller, and it has a wave in the middle before the phase 2 actually starts. Now, say you've intubated too far and you're down 1 bronchi. Well, this frequency, rhythm, and height can vary. Baseline can be 0, a little bit elevated, but ultimately we're not going to have any true phase 3. It's just going to be kind of rounded at the top. So for instance, this image is the endotracheal tube is down the right bronchus. So we're seeing no phase 3 when we are evaluating this capnogram. If anyone has any questions, don't hesitate to send me an email, make a comment. I am always open to ask questions or help you understand something if I was a little confusing. Thank you. Here are the references that I utilized to help put together this PowerPoint and this presentation, as well as this video. I hope you enjoyed this as much as I did. Thank you and have a good day.